Hi, everyone. Welcome. We're going to give it just a few moments as people join us. We still have a few people logging in, so just give us a few more moments. We're ready to start. Welcome, everyone. I'm Karen with Mended Hearts. I'm so happy you're joining us this evening. We are in a position to learn a lot tonight, so I'm really grateful you're taking time out of your day to get some really solid education. So tonight's topic is understanding stroke and its connection to cardiovascular disease. Before we get started, I'd like to give a big thank you to our sponsors, BMS and Johnson & Johnson. Without their support, we couldn't offer this amazing opportunity for you all. And a few housekeeping items. All of the attendees are in listen-only mode. We will not be able to answer any questions related to your specific medical condition. Be sure to type your questions in the Q&A box so we can answer at the end of the presentation, or I'll kind of keep my eyes on it. And if there's anything relevant that's coming up as the speakers are speaking, I'll be sure to hop in and make sure we get your questions answered. And also, this webinar is being recorded. It will be available on the Mended Hearts website and our YouTube channel. And it's my pleasure to introduce to you tonight Dr. Karan Nathani, who is a board-certified neurologist specializing in vascular neurology. He serves as the medical director for the Suburban Hospital Stroke Program. Suburban is part of Johns Hopkins Medicine, located in Bethesda, Maryland. Dr. Nathani earned his Doctor of Medicine degree from the University of Nevada, Reno School of Medicine in 2019. He completed his internship in internal medicine and residency in neurology at the University of Maryland Medical Center in 2023. Dr. Nathani completed his vascular neurology fellowship at the NIH in 2024. He is a member of the American Heart Association and has contributed to numerous research initiatives and is actively engaged in process improvement to help improve the outcomes in patients with stroke. Dr. Nathani, welcome.
Thank you so much, Karen and Lisa, and to the Mended Hearts organization for inviting me in to discuss such an important topic. And thank you all for joining today. I'm just going to take a second to share my screen. Is that showing up?
Yes, we got it. Perfect.
And that's the correct.
Yes, that's the correct format, everything. Looks like you're all set.
All right, perfect. So yeah, as Karen had mentioned, I'm the medical director of the Johns Hopkins Suburban Hospital Stroke Program. When the title of the talk that I came up with is "When it comes to stroke, be fast." And so, be fast is really a mnemonic or an acronym to remember to try to make it easy for people to remember the signs of a stroke and how to spot them, because as we'll discuss, time is an incredibly important component in stroke care, and I'll get into that more once we get further into the presentation. But I just like to start by just going over BFAST, just so that we get as many repetitions of this, because this is probably the most important thing to take from this whole talk. So you will see this a ton. And there will be some themes that develop as we continue to talk. So B stands for balance, E stands for eyes, F stands for face, A stands for arms and legs, S stands for speech, T stands for time. So to break it down further, so the B for balance is if there's any sudden onset of loss of balance or coordination. For eyes, any changes in vision, such as double vision or loss of vision. F, any grouping of the face, which I'm sure many, if not all of you, are familiar with. And then arm and leg weakness, on one side of the body, typically. Speech difficulty, so either difficulty in understanding or talking and producing words, or slurred speech. Then T is time, call 911. so that you or your loved one can be taken to the hospital immediately. Now, it's truly a time sensitive condition, and so we'll get into the reasons for that as we go along. So before I start, I have no relevant financial disclosures. Um, and so, while I cover many aspects of stroke care during this presentation, the goal will be to equip you to recognize stroke symptoms for swift action. We'll start off by defining stroke, providing an overview of the statistics and risk factors, explain the in-hospital process of stroke care. So why does stroke matter? Why is it such a big deal? So this picture here is from the CDC. It just kind of shows the average stroke hospitalization rates across the country, and you can see in this area, in the southeast United States, known as the stroke belt. That purple gets really really dark. And it's so the causes of the elevated incidence or the amount of strokes that happen in the southeast haven't really been fully determined, but it's probably multifactorial. There probably is a difference in the amount of high blood pressure, socioeconomic differences, diet, and other lifestyle factors. But in the U.S. in total, there are around 800,000 patients who have a stroke annually, and about 20% of those have another stroke, within the same year, within a year of their stroke. Some other, statistics to cover is that every 3.5 minutes, someone in the U.S. dies from a stroke. It's the fifth leading cause of death in the U.S., and it's a leading cause of long-term disability in the U.S. And this image here shows that over time, since they've been, this is also from the CDC, but from 2000 to 2015, we've seen that the deaths from stroke have been decreasing, which is encouraging. But in terms of globally, how prevalent is this? It's the second leading cause of death globally. It's the leading cause of disability worldwide. And again, the time is ever so important, and quick actions can save lives and improve recovery after a stroke. So the one other thing that I just wanted to briefly talk about before we start, answering the question, what is stroke? What even is stroke? Is, traditionally stroke has been perceived as a disease of older age. However, it really can affect anyone. We're seeing, this graphic here shows that there's an increase in increased rate of stroke in patients. And this particular study looked at patients as young as 5 years old, up to 44 years old. And the only group that they found didn't have a statistical increase in incidence of stroke was females aged 5 to 14, but it's unclear why that why that population is did not we didn't see an increase in them. But every other group, boys age 5 to 14, up to 44, right, had an increased rate of stroke. So I've told you about all the reasons why stroke is a major cause of mortality and disability, but what actually is a stroke? Well, I'll start by saying a stroke is a medical emergency. So unlike other medical emergencies, the most one that's very similar to a stroke is heart attack, right? With a heart attack, you have sudden onset of chest pain, and shortness of breath, and it's very scary in the moment, right? You have this surge of adrenaline and all that, but stroke, the brain doesn't really sense there's no pain really, not that often with a stroke. And so sometimes people do decide to take some time and try to wait out the symptoms, and we'll talk about this a little bit more as we go along. But the first point is stroke is a medical emergency. It is caused by a loss of blood flow to part of the brain that ends up resulting in damage to the brain. And there are two types. There's an ischemic stroke and a hemorrhagic stroke. And a nice way to kind of think about this and conceptualize it is in terms of plumbing. And so ischemic stroke is, we can think of it as a blocked pipe, and a hemorrhagic stroke as a leaky pipe. And so here in this picture, you see, the blood vessel is open here, but there's a blood clot or plaque sitting there. And so essentially, there's a blockage, so the blood can't flow. And with the hemorrhagic type stroke, the blood vessel is damaged and ruptures, and then you have bleeding and compression of the brain around the bleeding, right? And so it's two different mechanisms, but they still lead to damage of the actual of the brain tissue. And we'll talk about more, I think, in a few slides about what that actually means long term regarding recovery and long term disability. And then I heard someone's microphone coming on. So was there a question? So sorry, I don't. Please stop me if there are questions, and I'll be happy to answer. All right, so
I was just going to add, there is one, but it's a little bit on the verge of medical advice. Someone's taken a medication for AFib and found out from an MRI of the brain that there's likely a condition caused cerebral amyloid angiopathy, CAA, based on evidence, as well as previous silent strokes. They're high risk. Is it safe to take a blood thinner with a diagnosis of CAA?
So generally, from just the educational standpoint, generally when someone has cerebral amyloid angiopathy, they're at very high risk of bleeding. And so, most physicians kind of, most stroke neurologists, will go as far as aspirin. There are other alternatives to taking Eliquis, such as a Watchman device, but it's just handled case by case, and essentially the risk is high. The essentially what cerebral amyloid angiopathy is this, these depositions of abnormally folded proteins into the blood vessels that essentially cause the blood vessel to become weak and more prone to bursting, right? So kind of more prone to causing these hemorrhagic strokes. But interestingly, we also do see that, there are these silent strokes also, and those are typically more ischemic in appearance, because, again, it's just damaging these blood vessels in the brain. And that does include these small blood vessels where, the impact of those may be in an area where there's no, the function of that area is well covered by other parts of the brain. That's why someone may not be symptomatic from one of these lesions.
Thanks.
Mm-hmm. That's a great question. And so, okay, so hemorrhagic stroke. So this is the burst, bulging and then burst vessel type stroke. It's the minority of strokes, 13%. And again, it's this an analogy of the leaky pipes here. There's less research in this part of the stroke, and the major American Stroke Association is really kind of trying to focus in, and the field is really moving towards trying to advance the research in this side of stroke now. And over the past few years, there's been a more concerted effort to try to develop like a bundled care approach to try to better handle these situations when they arise, or this condition when it arises, because the mortality is significantly higher than ischemic stroke with hemorrhagic stroke, and people do tend to do worse overall after they've had this type of stroke. And so the field is really trying to focus and developing better treatments and diagnostics and things of that nature to try to better address this problem, because the mainstay of treatment has stayed fairly similar, though in that the most immediate goal is to get the blood pressure under control, because most commonly this type of stroke happens because of high blood pressure. And so, but we're still trying to figure out, how fast do we need to get that blood pressure under control? Does it even matter? Those are things, we're still trying to address when we talk about hemorrhagic stroke. And, the other type of stroke, ischemic stroke, is the most common type of stroke. And it's, accounts for about 87% of all strokes. And it's analogous again to that blocked pipe. And so here, we have the heart here. So when we talk about blockage of a blood vessel, the blockage of the blood vessel, so you can see here, there's like this flat fatty plaque, right? And so you can see that sometimes when this fatty plaque gets deroofed, the contents underneath are very prone to forming blood clots, and so it can cause a blockage, or you can have blockage of blood flow through that area. So sometimes we'll refer to thrombotic stroke when the blockage happens at the site of the plaque, essentially. But with the heart, how the heart is involved is a blood clot can also travel and cause blockage in a blood vessel of the brain. And most commonly in North America, those blood clots originate in the heart. And due to a condition that we had already heard about, atrial fibrillation. So that is the most common cause of stroke, of ischemic stroke in North America. But essentially, and that's why, it's for atrial fibrillation, it's one of the mainstays is, being on blood thinning medications to try to prevent this kind of event from happening, thromboembolic events. And so when a blood clot originates in a different organ and travels to it and causes a blockage in another organ, we call that an embolic stroke. If it travels to the brain, we call that an embolic stroke. It can originate from anywhere, but it has to be outside of the brain. And so, what about a mini stroke? So these are also known as TIAs, and so it's what's thought to be a temporary blockage of blood flow to the brain. It can last minutes to hours. In the 2010s, the definition was more time-based. So essentially, a person came in with symptoms. If their symptoms resolved within 24 hours, it was called a TIA. If it was persistent after that, then they would be diagnosed with a stroke. But since the 2010s, we've kind of moved towards this tissue-based diagnosis, since we have more access to advanced neuroimaging techniques, so MRI, CT scan, and so now, if there is damage on the brain, even if the symptoms are gone, we will call that a stroke. And I guess in essence, I think as our ability to look at the brain more closely, in other words, as our imaging advances, as our MRIs and CT scans are able to get down to a smaller and smaller resolution, I suspect we're probably going to see more little damage to the brain. With these events, even with these events, these TIAs that were previously thought to be, just these reversible transient blockage, and we've essentially progressed that definition to involve tissue damage. But at Suburban, we have a 3 Tesla scanner, MRI scanner, and we as compared to most other hospitals, I think a lot of them are moving towards the 3 Tesla scanners, but a lot of hospitals have more of the 1.5 Tesla scanners, and so we have a little bit of a higher resolution with our scans, and so I think it affords us a little bit more luxury in terms of being able to see that and make that realization that, hey, maybe there is a little bit of damage, where our other scanner might not have picked it up. So, and so what happens to the brain during an ischemic stroke? So time is brain. This is a very important thing to remember in stroke care, and that's again why I'm harping on why there needs to be urgency. If you or your loved one are having a stroke. Uh, and so the brain, just to think about it, the brain comprises about 2% of the body's weight, but takes about 20% of the metabolic demand. So it's really expensive metabolically, meaning, a lot of those nutrients and oxygens, your brain is consuming it, right? And so this is, where the whole connection with the heart is particularly important because, the heart, as we saw, has a direct connection to the brain. And a lot of that pumping that the heart is doing is really to keep the brain, full of nutrition and oxygenation. And so the neuronal death cascade after a stroke really, this is really the way to think about it. There's a blood vessel that gets blocked or clogged, and you can see that, it's nice and red here, and then on this graphic, and then you can see where it's blocked, and the lack of oxygen and blood flow past that blockage, and that typically causes, as an aside, this wedge-shaped appearance, because there's a branching pattern to the blood vessels, and so you can see it's got a little bit of a wedge-shaped pattern here. On the MRI, you can see that area here. That's where the stroke is happening. And so, essentially, the blood vessel gets blocked. There's now the brain, which is a big consumer of the body's energy, is not getting the energy it needs. And that ultimately leads to death of the brain cells. And so another important, this purple, this is really fantastic, that we have access to this, these perfusion studies. But essentially, this helps you understand, that stroke is a dynamic process. And you can see here, this purple area, this is where the blood flow has decreased below 30%. And so we define this as the core of the stroke. This is where the tissue that is irreversibly damaged is present. And then here, this T max greater than 6 seconds is essentially, for the CT perfusion studies, we're giving contrast and comparing the one side of the brain, how fast it's receiving the contrast versus the other side. And so this screen delineates all the tissue that's at risk. So, this could eventually become purple, right? And so that's where we really try to focus our efforts in terms of management of stroke. Is we want to keep the green, or we want to prevent the green from turning purple. And so this green signifies the area of the brain that is still able to be saved. And so, just to give you some more statistics, about 2 million brain cells die every minute. So, there's a slogan that kind of caught on, save a minute, save a day. And that's because, based on the study that found this finding, when a person loses these brain cells every minute without treatment, it ends up cutting lifespan by 1 to 3 days. And so, it caught on, just because it's catchy, save a minute, save a day. But again, it underscores that time is brain, and you have to move fast and not wait to try to wait this out if it happens. There was another study that found that, with every 30-minute delay, there's a 26% chance of decreased good outcome. And essentially, I've included these pictures here just to show you, that this is it's always going to be a bad situation, but the goal is to really act fast enough where you don't lose half of your brain in this example.
We have a couple of questions, Dr. Nathani. Should we just check these out?
Yeah.
Somebody's wondering if TIAs are common after open heart surgery, and what are the statistics saying regarding reoccurrence of another, more or less likely?
Yeah, so we have some good tools, and that's actually a project we're looking to start up at Suburban Hospital. So TIA is another. So the reason it's less. So to answer the first question, after cardiac surgery, TIAs are common. After cardiac catheterizations, TIAs are common. And so and by common I mean it's a known complication of the procedure, and you really hope it doesn't happen. But when we've at Suburban, we do research. Our research is really focused on brain imaging and how a stroke changes over time. And so, when we do have people that have come in with a stroke who, after a cardiac procedure, you can sometimes see, even if they don't have if they have they have like these kind of these silent strokes, if you will, silent infarcts, where there's one lesion that can explain why they're not talking, or why they're weak on one side, but there are other areas that have some damage. And this is the concept of silent cerebral infarction. And so that's just the nature of the beast, is that the heart is directly connected to the brain, and pumping blood to the brain. And when you're going through for a cardiac catheterization, you're going through the aorta, which is the big conduit artery that's coming out of the heart to pump blood to the rest of the body. There could be plaque on that you're disrupting and shooting up. But that's the first part of the question is so we do see that. And it is a complication that we fear, but we still have the ability to do something about, particularly, and I'll talk about the treatment options in a few slides here. And then with regards to, and remind me, the statistics regarding
reoccurrence of another TIA, more or less likely.
Yes.
Heart surgery.
Yep. So it's the risk factor itself is the fact that there was a prior stroke or a transient ischemic attack. So once that has happened, the risk of stroke and TIA will always remain elevated compared to someone who's never had those. And typically for a stroke, I know the statistic off my mind, it's after a year after you've had a stroke, you get down to around 4% chance of having another stroke. But your risk really remains elevated throughout that whole first year. And then with TIA, the other consideration is how severe was the TIA. With more severe TIAs, defined as those in people who are older, have high blood pressure, and have weakness as a finding. Those people tend to have a higher risk of another event, even within the first week after that first event. So, and it can be up as high as 9%. So, it definitely is seen. And I was sharing this with Karen earlier. But my father had a bypass, and that that was one thing I was recently, and that was one thing I was really nervous about. Was I was really hoping he wouldn't have a stroke, or something like that happen, because I've had I've seen it during residency and in my training, and I was it's just something, as a stroke neurologist, you worry about. So that's an excellent question. Thank you for the question. And then was there another question?
Yeah, we have a couple more. What are the primary tests for stroke prevention? For example, carotid, etc.
Yeah. So I think the biggest thing is and I'll talk. I was going to start addressing it a little bit in the next two slides, but we'll maybe breeze through those. But since we'll talk about it now, but high blood pressure. So you want to really nail down the high blood pressure. You want to nail down high cholesterol. You want to nail down your blood sugar management. Those are going to be your highest yield. With the availability of cardiac monitoring, I think it's a good idea, if you do feel like fluttering in your chest, you know, you could consider, you know, this isn't FDA approved or anything, but you know, there are Apple Watches that have the atrial fibrillation monitoring. There's also like different devices like the Procardia device. So there's different ways to really kind of use wearable technology to try to see if you have atrial fibrillation. And you know, you might not feel like heart fluttering or anything like that. It might not, you know, because atrial fibrillation can be what we say, we use the term paroxysmal, but it can come and go. It can be intermittent. And so, you know, it might not last long enough for it to come to your awareness, but that would be something else that may be high yield in terms of trying to just stay on top of, particularly if you do have a racing heart. But generally, what we recommend is, you know, to tackle the high blood pressure, tackle cholesterol, and the diabetes. And then, you know, just maintain good cardiovascular risk factor management, similar to, you know, somebody with coronary artery disease. You know, there are new tests that are being increasingly used by the cardiologists, and you know, I've been trying to incorporate them more into my practice, such as testing Lp(a), which kind of shows you the genetic component of high cholesterol. You know, because some people will say to me, you know, they're extremely healthy, and they'll say, why did the stroke happen to me? And you know, you check the Lp(a), and their cholesterol comes back really high, but you know, these are people that are really on top of their diets, really on top of exercise, and you know, still these values are elevated, and you know, it's at some point, you know, there's always nature versus nurture, and or genetics versus the environment, I should say, um, and in these situations, you know, the genetics may be playing a higher role in causing an elevated risk for stroke. You know, with regards to carotid ultrasounds, you know, if there are if you do have a history of, or a family history suggestive of you know, heart disease, stroke, then I think it probably is worth it to get the carotids checked, because you know, essentially what you're looking for is you're trying to see if it's narrowed, and you know, when we're talking about the carotid goes from your neck up into your skull, so we're talking more about the carotid in the neck, and so essentially the options are stenting or you know, carotid endarterectomy, where they clean out the plaque from the blood vessel. And so, you know, this is, again, you know, the heart can send clots and plaque up to the brain. So can the carotid artery, because the carotid artery is also directly going up into your brain. So you know, checking the carotid artery, and you know, I'll talk about you know, what we check for more in the next couple of slides. To you know, once someone has had a stroke.
I think we're all caught up on the questions, Dr. Nathani, if you want to keep rolling with your slides.
Right.
Yeah.
Yes, it's good. And so, you know, there are certain factors that are associated with stroke that are, you know, have been identified to the research through research, and you know, that are still being identified through research. Some of the recent articles I've read, you know, are looking at microplastics. I don't think we really know, you know, positive, negative on them yet with regards to how they're involved in the plaques. But you know, that's an area of research that I think people would find interesting. The other thing I recently read was, you know, pollution, right? And so with pollution, we really can't control that, right? It's, you know, where you're born, and I guess you could remove yourself from that situation, but you know, you probably have to wait till you're an adult. So you know, a lot of us probably, you know, are you know, that is one risk factor that, you know, has been linked to, that we can't really control. But you know, the major ones that are non-modifiable or risk factors we can't control include age, family history, race and ethnicity, gender, and prior stroke or TIA. And so generally the risk of stroke increases after the age of 55. You know, there have been over 395 genetic traits that have been kind of trace back to stroke. That not a single causative one, but there is a genetic link. And so a family member, first degree family member who's had a stroke at a young age, you do worry that someone else, one of the other first degree relatives, will have a stroke. And then, numerically speaking, women have a higher number of stroke, but they have a lower risk than men before menopause. And so, these are kind of the risk factors we can't control. But the risk factor, we really try to harp on the risk factors we can control. And this is the second part of the hospitalization. I know we haven't talked about the first part yet, but the latter half of the stroke hospitalization, when we're talking about prevention counseling, really focuses on these management of these risk factors. So high blood pressure, as we discussed, obesity, high cholesterol, cardiovascular disease, diabetes, smoking, drug use, heavy alcohol use, and not so much in the inpatient setting, but sleep apnea should be addressed at some point, because it does increase your risk for many different things that could lead to death or complications. So, for example, sleep apnea is linked with atrial fibrillation, and so check as well as advanced narrowing of the blood vessels or advanced atherosclerosis. So it really is, sleep is very important, and so making sure that the sleep is healthy is also something that I think is under investigated in stroke care and in general. But just to add a couple more stats, smokers have about a 2 to 4 increased rate of stroke compared to non-smokers or people who have stopped smoking more than 10 years ago. In terms of heavy alcohol use, that's currently defined as no more than 2 drinks per day for men, or 1 day for women. And then, with regards to diet, we've adopted I'm sure you've heard of the Mediterranean diet. So for stroke care, we generally recommend this diet. It's, kind of centers on, avoiding red meat, having olive oil, having, tree nuts, so not peanuts, but tree nuts. So it's the things like pecans, cashews, pistachio, walnuts. Avoiding these red meats and more focusing on lean meats, fish better than chicken. Beans and tofu are other good sources of protein. Fresh fruit and vegetables, whole grains. And then limiting salt intake. The American Heart Association recommends to limit salt intake for people, for healthy people, to 2,300 milligrams daily. That's 1 teaspoon. For people who have high blood pressure, that gets cut down to 1/2 to 3/4 of a teaspoon of salt. So this is it seems pretty challenging. I mean, but that is the recommendation, and I definitely think blood pressure management is really very important to try to prevent stroke. And I think it's an easily identifiable, right? I think it's very easy to go overboard on the salt. But yeah, so a few slides ago, we talked about the timely treatment. So again, reminding you, time is brain. And so 2 million brain cells, die every minute during a stroke. And, quick treatment leads to less brain damage. And so this all really starts with a call to 911. And what, we had discussed earlier with regards to hemorrhagic stroke, but, getting that blood pressure down as soon as possible is the mainstay there. And so the treatment approach is to, you call 911, you're coming to the EMS are going to pre-notify the hospital. So everybody should be waiting for, you or your loved one or whoever's having the stroke to arrive. And immediately going to obtain a glucose check. Because sometimes, low blood sugar can mimic a stroke, and correction of that low blood sugar can lead to rapid reversal of the symptoms. And so that's really the only blood test we really want to stop for before we move on to getting scans of the brain. And so at Suburban, we do things a little different. We actually get MRIs. We're an MRI first center, whereas most hospitals in the nation are CT scan. I don't know the statistic anymore, but back, I think when I was a fellow at the NIH, I think there were only 6 hospitals in the nation that were truly MRI first. That number has since increased, but with the CT scanner, it's less expensive, it's faster, you get a little bit of a lower quality scan, and it's particularly good for picking up on blood. So one of the treatments that I'll talk about is a clot busting medication. And so, what you're trying to confirm by getting a CT scan is make sure there's no bleeding. If there's bleeding, then the person can't get the clot buster. And then, typically, this is what a stroke looks like on CT. You see that compared to this side, there's this darkness there. But you don't see this typically until, at least 6 to 24 hours after. So it's not particularly helpful for diagnosing the stroke. You might see some subtle signs like some swelling or things like that, but this particular picture would not be helpful in a treatment decision. But with an MRI, you can see what the abnormal tissue is here, and so you can see that it's a more detailed scan. It doesn't use radiation, and it identifies soft tissues, including the brain, and it can give you a lot more information about what's going on in the brain. So we can, for example, the person that asked about amyloid angiopathy, in our protocol we have a sequence that checks for cerebral microbleeds. And so that just helps inform our decision, with regards to treating, what the safety of offering the blood clot busting medication to someone, because with the CT you don't get that information. I should step back. With amyloid angiopathy, we would, this would be a very, it's contraindicated to really offer the clot busting. I'm talking about, people who have some small microbleeds, like a small amount, less than 10 per se. But it allows you to have that discussion. Hey, you might be at a little bit higher risk of bleeding. Do you want to proceed with this treatment or not? It just allows a better joint decision. And so yeah, I'm a believer in MRI, and we've kind of looked at numbers. We have benchmarks and things, and our treatment times, the fastest treatment time, that I've seen in my career is 12 minutes, and that was with the CT based center when I was in training. But we've gotten our times down. We've had a couple of 16-minute treated cases, and I certainly feel that with MRI, it's a lot. It kind of takes a lot of the guesswork out, and also helps you make a better decision. But again, it's incredibly hard to optimize an MRI. This has been like before my time, 25 years of optimizing to get to this point. So I understand, the challenges. And so, the treatment approaches for stroke include IV thrombolysis. So the medication here I'm showing with the syringe is tenecteplase. This is a recombinant form of tissue plasminogen activator, which is an enzyme in your body that prevents clot from forming. So, essentially you're producing a different form of this in your own blood vessels to prevent the blood from forming blood clots. But this essentially allows you to have a little bit of a higher than physiologic dose to try to get around that, try to dissolve that blockage. And typically this is changing now, but until recently, the recommendation was it should be administered within 4.5 hours of when a person was last seen normal. At Suburban, because we use MRI, we were able to time strokes a little bit better. So we would actually go off of 4.5 hours of symptom discovery if the MRI matches that. But now, there's increasing evidence that we can use those perfusion studies that I showed you earlier to try to guide the decision making. So that time window is kind of changing, to about 9 hours now at some centers, with some centers even pursuing treatment up to 24 hours. And then the second treatment modality, which is arguably the most effective treatment that's ever been developed across all of medicine, is a thrombectomy. And so essentially, you take a wire, kind of similar to a cardiac catheterization, but you're threading the wire up to the brain, and deploying either a stent or we don't stent the arteries of the brain. We've had studies that showed harm, but essentially you're taking the stent to try to remove that blood clot from that's causing the blockage. And here in this picture, you can see that the carotid artery is blocked. But then, after they've done this treatment, you can see here it beautifully fills and the blood flow has been restored, which, again, it's just magnificent when you see this, like in real time, and you see, the effects of the restoration and blood flow in terms of, the pictures at least right away. And you can see the major difference, right? You're not seeing anything past this point here where it's blocked, where they've injected the dye and the dye is not moving. But now, they inject the dye at the same place, and you see that, everything in the brain here is kind of filling up as it should be. And so, current research is looking at expanding the indications and ability to treat people with both of these treatment modalities. And so, again, stroke is ever changing. There's multiple things that we won't talk about just because of how heterogeneous of a condition it is. And but it's there's a lot of research being done as to how to improve outcomes, recovery, and a lot of different aspects of stroke care. And so recovery after stroke is really divided into three kind of phases. We have the acute, subacute, and chronic phase. Acute phase lasts out to a week. Subacute is 1 week to 6 months, and then chronic is after 6 months. In the past, so I guess I'll take a step back. The fastest improvement is really in this acute to subacute phase, so in that immediate after stroke to 6 months out. In the past, the research kind of estimated that neurological recovery really kind of plateaued once a person has entered into the chronic phase. However, newer research has come out showing that patients can continue to recover past that 6 month, well past that 6 month period. So, I don't think we really know when people really stop recovering after a stroke. And in the past, the stroke recovery has kind of focused on compensatory strategies. So, compensation involves doing something you were able to do before the stroke a different way. So, for example, if you've got weakness in your arms, now you're involving your torso to try to get your arm up, right? Or using more nonverbal cues to try to communicate with someone. But in the mid 2010s, as neuroscience research kind of progressed, and people were exploring neuroplasticity, the goal shifted from compensatory strategies. We still use them, but it shifted towards seeing recovery, right? So recovery means being able to do something the way you did it before you had your stroke. And it's amazing, how much people can actually recover. I have a patient who essentially lost half of her brain, and you would not be able to really tell that she had a stroke. She's walking around, she's talking normally. Of course, she notices things that are different, and her husband does, and people that know her notice it. But it's really for someone who's someone. But then I have people who have smaller strokes who are very disabled from their stroke. So it's still, stroke recovery is still an area that, of opportunity, because I think the story is still being developed, and I think in the mid 2000s, when the focus started shifting towards recovery, I think we've really seen a change, a dramatic change. And I mean, it might also just be the fact that people are getting treated sooner, and and stroke is being more recognized, and people are doing better from that aspect. It's hard to say, but again, timing of therapy, even with this, is important. So we still think that the fastest recovery happens in those first 6 months, and so efforts are ongoing to figure out um, how to maximize the recovery in those 6 months. And really, with regards to the timing of therapy, there was one trial that looked at intensive uh, physical therapy within 24 hours of stroke, and unfortunately, that did show that there was harm with that. So generally, someone will. It's generally recommended to be on bed rest, for the first 24 hours after a stroke. But again, I think that it's possible that a smaller dose of physical therapy earlier could be beneficial. Is this hard? These are the questions that are left to be answered. And so now that we've covered everything, I just want to get through a scenario, and just want you guys to ask yourself, what would you do if you or a loved one suddenly develops third speech and right arm weakness? And as I go through these next slide, I'll just say what you should not do and what I've seen. People have waited, either because they don't want to, they think it's something transient, or one reason that I've had in the past was that they were embarrassed that their neighbors would see. And then don't drive. Definitely don't drive. Please don't stroke and drive. And the reason for this is we've had there's multiple reasons, such as stroke, again, relating to stroke being a dynamic process. You don't know if your stroke is going to cause you to lose your ability to breathe on your own or stay conscious. And so, it's very possible that you would lose consciousness while driving, or lose awareness and end up, harming yourself or someone else. And there are a multitude of reasons. I feel like that's probably enough to convince most people to not drive. And then, don't ignore the symptoms. But what to do is call 911 immediately. And this is where EMS really comes into the importance of the EMS. So just to give you a little backstory, in 2000, the Brain Attack Coalition proposed the idea of a primary stroke center. Since that model and designation has been adopted, there's been improved long-term functional recovery, decreased mortality, higher rates of treatment, and faster evaluation of treatment times. In 2003, we did a study at our hospital, and I'm saying we, as I was not here in 2003, but my predecessors were here, and essentially 2 years after Suburban Hospital achieved the designation of primary stroke center, we had a 7-fold increase in our treatment rates. And so, we really see these improvements. And with regards to EMS, they're a vital component of this system because they're trained to recognize stroke symptoms. They're equipped with the ability to pre-notify and make the decision to appropriately route someone to a hospital that's able to provide the services they need. So whether it be administration of the clot busting medication, or a thrombectomy, because not all hospitals do a thrombectomy or have the staff to manage someone who needs a thrombectomy. And so again, driving, you might if you choose to drive yourself, you might end up going to a hospital that might not even be able to properly treat what you're going there to be evaluated for. And so, yeah, I beat that horse enough. So the key takeaways, stroke is a neurological emergency. Call 911, and when it comes to stroke, be fast. I'm going to end this presentation just by going through be fast. Just bear with me, and that's because serial position effect. So most people remember the first and last things they see and hear about. So I'll go over B fast again. So B stands for balance, so loss of balance, headache or dizziness. Eyes is E, so blurred vision, loss of vision, double vision, any kind of changes in vision. F stands for face, so one side of the face is drooping or weak. A stands for arms or leg, and weakness on one side of the body in the arms or legs. Speech is S, which is speech difficulty or inability to understand. Even reading, inability to read, that will count. And then T is time, call 911 immediately, or whatever your country's emergency number is. And so with that, I really appreciate everyone's attention. Stroke is a cardiovascular disorder, and healthy heart, healthy mind, and it's certainly responds to lifestyle modifications that you make to keep your heart healthy. So I'll leave you with the story of a patient I recently saw. She was in her, I'll just say she was, young adult, mother of two children. She fell in the shower. Her eight-year-old daughter recognized that she was having stroke symptoms. She asked her younger sister to stay with her mom while she went and called 911. 3 days later, this woman walked out of the hospital, and these girls are heroes, and they saved their mother's life. But I mean, this just underscores, that you have a role too in spreading awareness and helping to improve your community stroke outcomes. So please share, the knowledge of BFAS and the ability to to recognize stroke symptoms and advocate for more resources to support your EMS and local stroke programs, and be a champion for stroke by participating in community events and just spreading awareness. I'm really I would love to hear how, I wish I had asked her, her 8-year-old daughter how she learned about stroke. That's something I'm kicking myself for, because I think it would be great if people just became aware of this condition more, so that people could get to the hospital faster. Still, even now in today's day and age, only 25% of people, 1 in 4 people who are having a stroke, get to the hospital in time to get treatment. So again, we've got a lot of improving to do. But again, thank you so much for your attention. These are my references that I used to draft this presentation, and I'll open it for any further questions.
Thank you so much, Dr. Nathani. We only have a couple, but I think we're going to move on and hear our patient and caregivers part of the presentation, and then we'll kind of come back to some of the other questions that have been added to our list of questions.
Yes, please.
Okay. All right. Let me switch gears here. So I'd like to introduce our audience to Steve and Beth Bridges. Steve and Beth live in Greenville, South Carolina, and have been happily married for 53 years. Steve worked as a financial advisor with Edward Jones until his retirement in 2015. In July 2016, Steve experienced a heart attack and successfully underwent quadruple bypass surgery. 2 years later, in December 2018, he suffered an acute ischemic left MCA stroke. Thanks to dedicated rehabilitation, his strong faith, and many prayers, Steve has made a remarkable recovery and enjoys good health today with no lasting effects from the stroke. So Steve and Beth, I'd like to welcome you all. Do you want to put your camera on, please, and take yourself off mute? And we would love to hear your story. Okay, I can hear you, but I can't see you. There should be a camera bottom left of your screen, maybe, Steve. There should be a camera sort of that you can click on.
Anyway, you can If you can hear me, that's fine. I did have a heart attack in 2016. 2016 and a stroke in 2018. I had
I'm sorry, Steve, we're having a hard time hearing you. There's some echo and are you still there? I think we may have. We'll circle back to Steve. Let's kind of revisit some of the questions we have here for you, Dr. Nathani. Hang on. Let me just shift gears here and we'll go back. I know I had a couple of questions for you. What about genetic testing in terms of determining your propensity for a stroke? Is that such a thing?
Yeah, so right now, so there are a couple of conditions that are monogenic, meaning one, we've identified that one particular gene causes that elevated risk of stroke. But we don't normally obtain those unless, strictly at this time, they're mostly for diagnostic purposes, and we can't really do anything with the
I
information
don't know how
at
to
this
get
point
it
that
to
we
set
obtain
it.
from
It
them
usually shows you.
from those tests. But there are currently because there are so many different genes involved. There are people working on um, coming up with risk scores that kind of combine all these genes together to try to predict stroke risk. In oncology, as your son, is probably learning and will learn about, is the treatment has really gotten to that personalized level. We're still working on that in stroke.
And so with stroke, it would be a blood test. It's as simple as a blood test.
Yeah, or it would be a
Swab.
swamp, yeah.
Yeah. Can you talk to us a little bit about the differences between stroke symptoms? Is there a difference between men and women and the symptoms that they experience?
So I think so no, not in terms of the symptoms, but I think in my experience, um, I've seen at other, there was a study out of another center that kind of looked at women and whether they were getting appropriately the appropriate recommended treatment for secondary stroke prevention. And in that study, they kind of found that we don't really know what the reason for this is, but it might just be that there was some bleeding increased bleeding risk associated or something else that was accounting for this. But what they found in that study was that generally we use aspirin and Plavix a lot together to at least in the first 21 days to 3 months after a stroke. And what this study found was that they noticed that in women, less women were being discharged from the hospital on aspirin and Plavix when they should have been discharged on that. When they would have normally should have been discharged with aspirin and Plavix.
Mm.
And so it's not really, there are still, whether it's unconscious or conscious, but there are disparities that the field has to address. And I think it goes a long way to just implicit bias training has been increasingly incorporated into training, and it was definitely part of my training, and so I think that's something that's becoming more prevalent.
Yeah. Thank you for that. Let's see, I had another question about CT and MRI, but you already answered that, so thank you for that. What about, so another one on here. This one looks pretty specific. Oh, here's one. One of the last couple of questions before we close out tonight. What if it's you having the stroke and you are alone? Any tips for that?
Yeah, I mean, calling 911, and then there's some, there's less data for this, but I think there is still some data that suggests, lying down kind of and helping the blood, it helps the blood kind of get up to the brain. But the problem with that is, if you're vomiting and stuff like that, then it might be more dangerous to do that. So, it's just really, the option is calling at 911 or texting someone you love. I've seen that, where there was someone who I saw recently who was on vacation and essentially texted his sister, like I think he realized he was having a stroke and just started texting his sister, and he didn't have any language, like his language was affected, but in that he texted his sister and it was garbled and didn't make any sense. She was able to figure out that something was wrong and essentially got him the care he needed, out of state. So.
Wow. Okay, let me just do a quick roll through here. So unfortunately, I think we're having some technical problems with our patient and caregiver, Steve and Beth, but we will record them separately and certainly make it available to everyone. I think it's really important in my own experience as a cardiac patient to hear from other patients. I think it's very useful, and it's always interesting to hear other people's stories, especially with his wife, Beth, being involved, because so many of our successes are dependent on our caregivers. So I believe we've answered all the questions. I think.
I see a couple. So why does AFib increase stroke risk? Atrial fibrillation essentially is, you have these two chambers. Your heart has four chambers, but for simplification, the top chamber is called the atrium. It kind of collects the blood that comes in from the lungs, and then you have the bottom chamber, that's the ventricle, that kind of squeezes it out to the rest of the body. In this situation, in atrial fibrillation, the atrium is kind of not is jiggling because of an electrical abnormality. It's kind of jiggling inappropriately, and that causes the blood to pool and form blood clots, and then that ends up shooting up and causing a stroke. And then I see a question from Bianca. So I can't give special recommendations because that would be, medical advice. But with regards to the sequela, long-term sequela of stroke, or the things that persist, right? Even after you have, if, say, for example, a TIA, as we had discussed, doesn't, as far as our current definition of it is that there's no damage that's left on the brain. But in people who have TIAs, who have stroke, we do see this accumulation of silent infarcts or strokes that accumulate over time, and sometimes those will be written in a report with the term white matter hyperintensities or white matter disease, small vessel white matter disease. Those are terms, and so it could be that there is just this these little accumulations of this damage that's happening over time that's leading to these kind of symptoms. But the alternative is if for example you were diagnosed with a stroke, or you had a TIA before this whole definition of TIA changed, and you didn't get the imaging, and maybe there was some damage from that TIA that was left over and it was actually a stroke. And so you definitely again, going back to compensation versus recovery, your goal would be to try to challenge yourself to try to make sure that the memory improves through cognitive rehabilitation strategies, so like memory games and things of that nature. But yeah, it's again, the importance of continuing to follow up with your primary care and addressing and maybe even being referred to a neurologist for people who have these long-term sequelae could be helpful in trying to determine appropriate treatment plan and evaluation plan.
Well, thank you so much, Dr. Nathani. You've been so thorough, and I really appreciate you sharing your expertise and your time with us tonight. I know I've learned it a lot, and we're getting a lot of really good compliments about the presentation tonight. So, again, thank you to everyone that was able to join us tonight. And Steve and Beth, we will be in touch to work out that portion of it, and we will, include you in the video. So good night, everyone. Thank you so much.
Thanks again for having me.
All right. Good night.